So hi everyone on the call. My name is Omar Sino. I'm the medical strategy lead at UCB, specific to rare neuromuscular disease in the US. On behalf of UCB, I'm happy to be a part of the MDA's webinar series. Today we have Dr. Vu, who's going to be going over our contribution to myasthenia gravis. Dr. Vu is the professor of neurology and the director of the neuromuscular division, gMG labs, at the University of South Florida, which is also an ALS Association certified treatment center of excellence. Dr. Vu is the principal investigator for many clinical trials involving patients with MG, ALS, CIDP, myositis, and other neuromuscular conditions. Dr. Vu graduated from the Pennsylvania State University College of Medicine and completed his neurology residency and neuromuscular disease fellowship at Columbia in New York. And now I will turn it over to Dr. Vu.
Thank you very much for this opportunity to talk to you about two relatively new approaches to the treatment of generalized myasthenia gravis, and to discuss the work and the trials that are ongoing in regards to two new medications, Rozumab, which is a mouthful, so I'm going to refer to it from here on as Rozumab. It is a FcRn antagonist, and the second medication is Zilucoplan, which is a complement factor 5 C5 inhibitor. As Omar said, I'm the site principal investigator for both the phase 2 and phase 3 clinical trials testing Rozumab and Zilucoplan. I am also the principal investigator for several other clinical trials sponsored by different entities. And I'm a speaker and consultant for Alexion and Argenex. MG is actually a pretty rare disease. You can see here the list of incident across the globe. In the United States, the incident is about 10 per million, resulting in about 60,000 affected individuals in the US. There is an international consensus guidance in the treatment of MG that was first published in 2016, revised last year, and published earlier this year. And the guidance suggests that the goal of treatment should be the minimal manifestation status, meaning that you basically have essentially no symptoms, using medication that have at best mild adverse effects. So here's a goal that's actually pretty hard to achieve, and there's a recent survey that showed for patients who are moderately affected, many of them felt that the treatment is not actually directed specifically against the underlying pathophysiological mechanism, or bring them to where they have minimal symptoms. So there's a lot of unmet needs for this particular disorders, and we're fortunate in that there's a lot of studies ongoing to arrive at a logical and effective treatment. I'm going to talk about Rozumab first. FcRn, or the neonatal Fc receptor, is involved in the natural recycling of IgG. So the plasma cell would produce the antibodies, including the autoantibodies that we see in myasthenia gravis, and that circulate in the system. And the half-life is about 21 days, and they get degraded by being absorbed by the endothelial cells. And if they bind to the FcRn, they actually get recycled and get released back intact into the circulation. If they are not, then they become degraded in the lysosomes and taken out of the circulation. So, it's logical that if you block this receptors, you would reduce the recycling rate and enhance the degradative pathways and reducing the antibodies in the system. So that's the whole idea behind blocking FcRn. Rozumab is a monoclonal antibodies that target the FcRn with high affinity and specificity. So when it binds to it, the FcRn, the autoantibodies, don't get recycled and get taken away from the circulation, and therefore there are fewer of them to attack the postsynaptic neuromuscular membrane. And if you have less damage, you would assume that you would have less symptoms as well. So to test this concept, there was a study called the MG0002, which was a phase 2 randomized placebo-controlled trials of 43 adults with moderate to severe MG. All of these patients had antibodies to either the estrogen receptor or MuSK. And since the mechanism of FcRn blockage, removing IgG in general, is very similar to something else we use, plasma exchange, these patients must be good candidate for plasma exchange or IVIG to enter the trial. The study was completed in 2018, and there's actually a publication of the results out there. So the patient, if they undergone successful screening, would be randomized 1-to-1 to Rozumab, 7 milligram per kilogram, or placebo. And they got 3 cycles, 1 week apart of the treatment. And then we looked at endpoints at about day 29, at which point they also get re-randomized to 7 milligram per kilogram or 4 milligram per kilogram. And this was done basically to look at different dose and what's the minimum dose that you can get away with. In the second phase here, they again get 3 doses 1 week apart and then underwent an observational period. The primary endpoint was the gMG score change from baseline to day 29. There were also secondary and exploratory endpoints to this trial. To remind you, the gMG is a physician or provider administer measure. It consists of 13 items testing of domains such as ocular, bulbar, respiratory, and limb function. The scale for each item go from 0 to 3, 0 being normal, 3 being severely affected. The total score is 39. And like almost all of the measures we use in MG, the higher the score, the worse you're off. The ADL is a patient-reported measure. There's 8 items related to their activities of daily living. For example, double vision, trouble chewing, trouble swallowing, slurring speech, getting up from a chair, how far you can walk, all that. Again, the maximum score is 24, and you do not want to reach 24. Most patients, when they get to about 12 to 13, start to have pretty limited function in their daily routine. Sorry. Here's a summary of the phase 2 study. So here's where the patients start to get treated. And you can see that, like most MG trial, there's a really large placebo effect. But you do see some separation at the end here. Unfortunately, at 29 days, the separation was not statistically significant. And that may have been because it'd been 2 weeks since the last dose, and we know that the effect may have been waning by then. But if you look at the secondary measure of ADL and MGC, you do see a more clear-cut separation at day 29. In terms of adverse events, most of that were pretty mild to moderate in severity, and the incident was pretty similar. Headaches was a side effect of interest, and it was more common in the treated group, 57% versus 14% in the placebo group. In 3 incidences, it was severe enough for the patients to drop out the study. So roughly to summarize, this phase 2 trial indicated that the primary endpoint was not met. However, if you look at responder analysis, there were significant and clinically meaningful separation, improvement of 3 points or more in gMG, ADL, and MGC scores, suggesting some level of efficacy. The drug also was associated with few side effects and generally was well tolerated. And based on these results, it was worthwhile to continue development. And that happened in this study, the MG0003, or the myCaring study, which is a randomized double-blind placebo-controlled study looking at Rozumab in patient with generalized myasthenia gravis. After successful screening, the patient was randomized equally into 3 groups. There was 2 doses of Rozumab and a placebo group, and they got weekly infusion or injection for 6 weeks, and then they entered this observational period for another 8 weeks. At the end of that, they got re-randomized into the 2 doses again, and got treated for 6 weeks, followed by 16 weeks observational period. If they get worse during the observational period, they get treatment again, so that this cycle repeats itself. The only caveat is that your IgG level has to be greater than 2 for you to get treated again, otherwise you get a little drug holiday. The primary endpoint was the change in MG-ADL from baseline to day 43. There was a whole host of secondary and exploratory measures in this study as well. So the phase 2 was a proof of concept study that actually provided some really valuable information about the drug and dosing interval and such. So that was incorporated into phase 3. And phase 3 actually completed recruitment about 2 months ago, I think. So when the last patient from that study finished the treatment phase, the study should be, the data should be available for analysis. And I'm hoping that we should have the results in the near future. So that's treatment that I just mentioned reduced the level of autoantibodies in the body. So what would happen when you still have antibodies and those antibodies reach the neuromuscular junction? So the Zilucoplan would come into play at that point. So these 2 treatments you can look at as being related in the sense that they treat the disease at different point of the pathophysiological process. The complement cascade actually is a key mediator for some autoimmune diseases. It is a part of the innate immune system, and this is what we use to fight encapsulated bacteria. So it's a system of different immunologic proteins that's present in plasma on cell surface, and this cascade can be induced by 3 different ways. So you have the alternate classical and lectin pathways. If you have an antibody-mediated disease, the initiator is usually the classical pathway where C1 and a bunch of molecules get together and form C5. And once you get to C5, that molecule then split into C5a, which is a pro-inflammatory molecules where it's induced release of inflammatory mediators along with drawing in inflammatory cells. C5a also split into C5b, and C5b combined with C6, 7, 8, multiple molecules, C9 to form the membrane attack complex, or the MAC. The MAC is basically a hole in the membrane that leads to the destruction of the membrane. And that's what, there's evidence to show that that's what actually is what happened in neuromuscular, at the neuromuscular junction in myasthenia gravis. So Zilucoplan is a small 15 amino acid macrocyclic peptides. Because of its size, it readily penetrates the basal lamina and can localize to the neuromuscular junction. It targets C5, and by binding to it, it blocks the terminal complement cascade that lead to the formation of the MAC, as you can see here. And if you don't form those complexes, you reduce the damage to the neuromuscular postsynaptic membrane, and therefore allow more efficient transmission of impulses, and as a result, your patient may get better. So that concept was tested in the phase 2 study of Zilucoplan. This was a small study, proof of concept trial. 44 patients was enrolled. So after successful screening, they were randomized into 3 groups equally. The first group get 0.3 milligram per kilogram of Zilucoplan. The second group, 0.1 milligram per kilogram, and the third group get placebo. They were treated for 12 weeks, after which they were eligible to enter the open label extension, and they were randomized to receive either the low or high dose. The endpoints were the quantitative MG score from baseline versus week 12. And again, there were several other measures that serve as secondary measures, secondary endpoints. There was a wide range of age. As long as you're older or equal to 18, you can enroll, and the age went up to 85, which is pretty high for a lot of for MG's trial. You must have antibodies, and you must have symptoms as evidenced by a gMG score of 12. To avoid confounding the data, you must be on stable ongoing therapy, and you cannot have treatment that may have a prolonged effect for at least 6 months prior to entry. Because it was a small study with few patients, there was some unintended imbalances. So you can see here that the high dose Zilucoplan group were older and heavier, but on other measures, they seem to be pretty balanced, including duration of disease. And the one unique thing about this study is that patient can enter after they were newly diagnosed. So there was a patient that's entered the study after she was diagnosed the previous month. But there were some patients who were chronic sufferers as well. There are patients that had the disease more than 20 years. Here's a summary of the results. You can see that like almost all MG trials, there's a noticeable placebo effect, but the drug effect is more robust, as you can see here. And you can, the other thing that you need to know is that the onset response is actually pretty quick. So you can see the separation at around 2 weeks, versus, any of the immunosuppressants out there. You may have to wait several months to see any results. And at 12 weeks after initiation of the investigational product, you can see a separation between placebo and Zilucoplan that was statistically significant. And that was also duplicated in the ADL scale or measure. This is the result for the higher dose. The lower dose group also had similar result, but not as robust. In terms of side effects, the drug was pretty well tolerated. And There was no meningococcal infections. As I mentioned, the complement cascade is vital in the body's response to encapsulated bacteria. So that's why they get vaccinated prior to initiation of therapy. There were two discontinuations. One of the patient in placebo group had an exacerbation and had to be rescued. The one patient in the Zilucoplan high dose group had a really prolonged hospitalization for an unrelated condition and had to drop out. In terms of serious side effects, we saw 3 in placebo and 5 in Zilucoplan, but none of them were considered related to treatment. In terms of the minimal manifestation status or the minimal symptom expression, 36% of the high-dose Zilucoplan group achieved that state versus 27% of the patient in the lower dose group versus 13% in the placebo group. Similarly, in terms of rescue therapy needed during the trial, the 0.3 group did not require any rescue. 7% of the patient in the 0.1 milligram dose require rescue versus 20% in the placebo group, attesting to the efficacy of this medication. Obviously, those results were promising enough to warrant further confirmation and development. And so we have the RACE study, which is a phase 3 international randomized double-blind placebo-controlled study to look at efficacy and as well as safety and tolerability in patients with severe to moderately severe to severe generalized myasthenia gravis. The aim is 430 or so patients to be enrolled across 71 centers across the world. The phase 2 was done in North America, so this is a more global study. The difference is that the ADL is now the primary endpoint versus the gMG as in phase 2. That has somewhat to do with the FDA preference for patient-reported measures rather than physician or treatment related measures. In this study, the higher dose that was used in the phase 2 was used. So patient was either randomized to the 0.3 dose or the placebo in equal fashion. And they got treated subcutaneously daily for 12 weeks, after which they have the option to enter the open label study with the 0.3 milligram per kilogram. Inclusion criteria, again, they must have antibodies and they must have symptoms, obviously, otherwise it's tough to assess. They must have antibodies, vaccination against meningococcal. And again, there's other measures to mitigate safety issues. So the study is still ongoing, but we're pretty close to the target population. So I expect the study to be completed soon, and hopefully we'll have results sooner rather than later, because it looks like a pretty effective treatment. That's the end of my presentation. I would be happy to answer any questions that you have.
Thank you very much, Dr. Vu. I don't see any questions in the chat, but I have a question, Dr. Vu, regarding the IgG levels in the MG003 study. You mentioned that they had to be greater than 2. What is the level that you start to get concerned for hypogammaglobulinemia?
I think below 2 I would be concerned. I think 1 definitely.
Okay.
But luckily the level bounced back pretty quickly. And people who have hypogammaglobulinemia at baseline would be excluded from the study. So you need 6 gram per liter to enter the study. So, the value when it dropped to that point is drug related. And at that point, we just sit back and wait for it to rebound.
Understood. Thank you. Oh, here's some other questions in, not in the Q&A portion, sorry. So is there, one of the questions is there any data on antibody positive versus antibody negative efficacy?
Not in these studies. Those seronegative patient was excluded. In the MG 0003 studies, you're allowed to have MuSK antibody in addition to, those patients with the anti-acetylcholine receptor antibodies. In the complement study with Zilucoplan, you have to have acetylcholine receptor antibodies.
Excellent. And one other question, if both these investigational products end up being approved, how do you view using them in a synergistic manner specific to an individual who is in crisis?
I think that's something to be determined, and there's a lot of talk among MG specialists about how we're going to use these medications. I can see using Rozumab as a rescue medication because the effect is fairly rapid and you can have a turnaround fairly quickly. The problem with complement inhibitors is that you worry about the risk for meningitis. So you may have to cover the patient for a few weeks with antibiotics until you can vaccinate, or you can vaccinate them, but you have to wait a few weeks for the antibody response to occur. And during that time, you have to have antibiotic coverage while you treat them with complement inhibitors. That's sort of a tricky situation, mainly because you have to choose which type of antibiotics, because a lot of them will worsen the disease. So I see complement inhibitors more of a maintenance therapy than rescue therapy in terms of logistic anyway. But, under the ideal circumstances can be done.
Okay, no more questions in the chat box. Thank you so much, Dr. Vu. It's been a wonderful presentation. And I think we can close.
Thank you so much for the opportunity.
Absolutely, thank you.